Hey, welcome to the Pharmacy Podcast Network. My name's Todd Eury, founder of the Pharmacy Podcast Network. And you can see, it's this side. My camera's weird. I am the RX Podfather. Launched the first podcast for the pharmacy profession in 2009. And I did it because I didn't know anything about pharmacy. That's literally the truth. I kind of knew a little bit about pharmacy, but I knew that my life was going to stay in a section of healthcare that I was passionate about. And pharmacists have done things to medicine, into healthcare, and to treatment that I never, ever would have known when I entered in 2004, 20 years ago. I'm getting old. So when I pull together business people and experts and people that are dialing into pharmacogenomics, and when we start really thinking about how can pharmacists participate, we had to bring them into the Symptomatic podcast review panel because this is fun. I have had the honor to help out with the iHeartMedia channel, which is run by a team of passionate people that want patient stories told with intelligence and positioning and description. And so Symptomatic really makes it fun because it's a mystery. I mean, you don't know. And listen, I'm the consumer. I'm the one that's coming at this non-clinically, and to have clinical friends that you can send something to and be like, can you guess this before the end of the podcast? Or you're able to really dial into what that means as a clinical leader or somebody that's been in business that understands something in healthcare. So I want to welcome my panel, starting with a podcaster who reinvented pharmacogenomics and what that meant for our network. We reset that podcast hard about 2 years into it. Becky actually shamed me. She's like, this is not good. We need to reformat this. Dr. Becky Winslow, welcome to the show.
Hi, everybody. Thanks for having me. Todd's right. We made some significant changes.
We did. All right. The pain guy. This guy's amazing in my life. He lived close to me. He's down in West Virginia. He is certified in mass. What was it that you were? It was the
mass destruction mitigation or something like that. That hits the fan. We've got a certificate. Don't worry, we have one for everything.
That got him some attention from powers that be that wanted to know what that meant. But the pain guy, my friend, Dr. Mark Garofoli, welcome. It's great to have you here.
Thank you, Todd Castor. Always a pleasure. Representing as pain guy here. Thoroughly always enjoying grabbing a mic, respecting the mic, not giving opinions, but giving the facts, giving the stories. This idea of symptomatic overall, it's storytelling, and that's where everybody on this panel, that's where it's at. We can throw some facts at you, probably won't remember them, but tell a story.
Yes.
It's ingrained in here, and that's really where it's at.
It's absolutely. Thank you. Tamara, such a special person in the network and what you represent, and how you've brought a cutting edge or bleeding edge study in moving forward what pharmacist impact is going to have on healthcare and people's lives, but then nutrition and being able to dial into what we're eating and how fascinating that is and how that's an exploding trend. So I like being on the edge, but introduce yourself to our audience tonight.
Hi, everyone. I'm Tamara. Yes, I'm a pharmacist specializing in nutrigenomics. I took a little pivot to not just focus on medications, but also focus on our genetics and how the food we eat, the environment that we put ourselves in, affects our genes. And interestingly, I'm able to merge both the pharmaceutical aspect and the genomic aspect with the clients that I see.
Yeah, this is going to make a lot of sense in tonight's discussion with Symptomatic. Stephen Beckman this is where the studio is. He's not here. He's actually out and about because he's always traveling all over the place as CEO of Raw Pharma. But a client, a friend, a fellow Brownsvillian. Is that what we call them? A Brownsvillian?
Sounds good to me.
It's so good to have you here. I appreciate you being here tonight.
Well, it's a pleasure to be part of this panel and a part of these really smart people that you've invited. I'm the guy that spent most of my career on the pharmaceutical manufacturing side, but I think we have some really important stories to tell. There's a lot of misunderstanding as well as a lot of good understanding of what we do. But most importantly, we're in the position as the suppliers of the tools and medicines that we use to do it responsibly, to do it in a way that ensures great patient outcome. And I'll date myself, but I've been doing this for about 35 years. And I walked into it with the idea that I had 3 job offers out of school. One was to sell Coca-Cola, one was to sell Armstrong flooring, and the last one was to a couple of opportunities in the pharmaceutical industry. So I sat down one night with my father and I said, well, what should I do? He goes, well, what do you think would mean the most? And I said, well, I think pharmaceuticals might be a good place where I can do something good. So instead of giving people diabetes with Coca-Cola, I've spent my career helping people hopefully derive better outcome through proper choice of the right medications within their treatment regimen. So it's a pleasure to be here.
Thank you for being here. I appreciate it. All right. I tell you what. So if anyone remembers the HBO, one of my most favorite shows of my entire life ever, I was addicted to this show, was Succession. So if I were to make a show right now, if you just dropped me $350 million and let's go make a show, I would make a show that was the opposite of the type of people that Succession were kind of about, where they were, shystering and trying to get up ahead. But Ryan would be the opposite, but it would still be the cool succession strategy mind. This man's mind is blowing me away. And I met him on Instagram, and I'm very fortunate that we met, Ryan, and I'm excited that you're here.
Yeah, thanks so much for having me. Like Todd said, my name is Ryan Paul. I'm actually a pharmaceutical epidemiologist by trade, but I've spent most of my career as a serial healthpreneur. I spend most of my time investing in startups and had the privilege recently to take the helm of an organization called Mango Health that provides on-site pharmacy management for mental health and addiction treatment facilities, which is a part of my story. I'll look forward to telling that tonight as part of our conversation. So thanks so much, Todd, for having me. And you're no doubt there's some brilliant people on this panel. I'm excited to have the conversation.
Me too. Thank you so much. So this is Symptomatic. This is a podcast that was about something that was happening in a patient's life that they didn't understand. They received a headway or an initial diagnosis. They start worrying about it. So right out of the gate, I'm going to give my stage of this. I'm the consumer. I listened to these because I was really interested in understanding what was being missed based on what I understand about pharmacy, and soaked in this for 20 years now. So I was coming at it from a very sincere perspective. However, which stalled me was the stress. In episode case number 19, patient was Josie, that I felt that I wasn't able to understand where to even push them because of how complex the actual conditions were as I was listening to the stress in their voice, blah, blah, blah. So I started losing track of what I was supposed to be doing. I was supposed to be listening to these podcasts to really get a specific grasp, and then the patient pulled me in. And it impacted me and made me start researching the issues and the me putting myself in that position. So right out of the gate, I want to go to Becky Winslow, Dr. Winslow. I want you to kind of open up with Josie and
Sure.
give your feeling and background on it.
Sure. I mean, I think I'll start by saying that the patients whose stories that we heard, I wish I could say that they're unique or that this isn't a common situation where patients struggle to get an accurate diagnosis and to get the appropriate treatment. It's not, we call it practicing medicine because that's what we're doing. We're practicing medicine. And especially with conditions where the symptoms are general in nature, not specific or unique to the condition, doctors have to go through the differential diagnosis process. So not that these stories are unusual, but you're exactly right. It can be very challenging as patients try to navigate the healthcare system. As a patient myself, I find it stressful to try to navigate healthcare. I can't imagine navigating it not having worked in healthcare and knowing the systems and how to maybe get to the end point faster than if I was just out searching for answers. So I think for Jose, I think it's important to recognize that, once he was diagnosed, once his doctors were able to pinpoint what was wrong, then they started the trial and error process with the medications and trying to find a medication that would be appropriate for him. And although they did not mention medication names for Jose, I know as a pharmacist that there are certain medications that are used to treat patients with IBS. And I also know that there is testing available that helps to make sure that those patients are experiencing therapeutic outcomes and less or lower rate of side effects than they have to. So I love the iHeart podcast episode on him, and I would love to add to the episode, those drug names and how we can help shorten those patients' roads to recovery. I think that was my biggest, oh my gosh, I want to jump in there and say this.
Absolutely. I get that. And I immediately started thinking of the world of pain and what we experience and how subjective it is. A 5-year-old in pain versus a 64-year-old in pain who's gotten used to living with it is going to rate pain very differently. So Dr. Garofoli, Mark Garofoli, the pain guy, I'm just glad that you're here. Talk to me from your perspective of Josie's case and how pain might influence that.
So, first off, Todd, I appreciate, as a pharmacist, these things are giving us wings, giving us voices. So I appreciate again being here. In listening to these podcasts, even beyond this case, it's one of those where you're automatically on the edge of your seat, but for various reasons. It's you're rooting for the patient, but then as a clinician, as a healthcare professional, as a pharmacist, I'm sitting there like, oh, why can't we just? And by the way, armchair quarterbacks rule. Hindsight is 20/20.
Yes.
When you're listening to a podcast, you're not in an operating room. I hope. I mean,
Right.
or maybe not. I don't know. Not a surgeon, just pharmacist.
There's a podcast.
Yeah.
Right.
But when somebody, you got like two options basically in cases like this. I saw this in multiple episodes for Symptomatic. Besides being on the edge of the seat or on the edge of wherever somebody's doing when they listen to a podcast, you either have the option where clinicians are not listening, and I mean like sit down, ears open, eyes off the screen, stop typing, listening, or turns out it's such a complicated case that no matter how much you listen, you're going to need some help, right? He's not a philosopher. He's a rapper. We know him as Vanilla Ice. He said it better than anyone. Sorry, guys and gals. Anyone on this panel could do. Stop, collaborate, and listen. It's literally the charge for these podcasts. Stop. I got the Podfather to dance.
I'm thinking of a song right now because I literally used to. We had 21 dances. I was literally one of those group guy things. This was the 90s, people.
Yeah.
You stood up and you showed up. So I was.
Hey, he's on like HGTV these days. So still semi-relevant. Maybe that was last decade. I don't know. But anyways, going back to it, it's, either not listening, and that's easily mitigated by, hey, let's stop and listen. And we see that, you go to an airport, the TSA agent is just typing away, and you're like, what could they possibly be typing? They're at 700 words. It's been 10 seconds. But when we see that in clinical care, it's a whole other story. So there's that option. But, a lot of these cases that we're listening to, particularly this one too, it's complicated. It's clinicians realizing and patients alike that you're not going to talk to one person that probably has the answer relatively easily. And that's tough. I'm sure we've all been there as patients as well, too, of the, oh my goodness, now we're in the other seat. And that's a story into itself always. I've had my kidney stone story during the pandemic and all that. There's, things you don't want to go through, particularly with pain. I'll go there, of course. And sometimes you don't even want to talk about it afterwards. Like, oh yeah, hey, that was fantastic. 5-star. I had a great time. But you can help others with the stories. And that's what, this case, pretty much all the cases on Symptomatic are doing, where you're helping other people, the charge of pharmacy, the charge of all healthcare, really. So, maybe that's too big picture, but I wanted to start there. So that's
no, that's appreciated. And I like that perspective, because pain does play into a lot of things. So
yeah.
Thank you for that. Tamar, I'm so excited you're here, because every time I was listening to this and we were staging this and I reached out to you to ask you if you wanted to do this, and you're like, heck yeah. I was so excited, because I'm like, all right, what does nutrition, what do substances, what does sugar, what does, avocado, like what do these substances do to us, right? And so you're bringing a perspective that's pretty special. So introduce yourself to our listeners.
Hello. Yes, Dr. Tamar, specializing in nutrigenomics, which is a science of how food affects your genes, plain and simple. One thing that really stood out to me, first I want to say before I get into like the genomics part of it, with Jose's case, is the support he had from his mother.
Yeah.
I couldn't imagine having to go through that by myself.
Mm-hmm.
So it's important that our patients have an advocate for them or support system for them. So fortunately, Jose had that. When I was listening to this, what went through my mind was, I wonder what kind of genetic variants he has that could have indicated that he may potentially have irritable bowel syndrome. Now, nutrigenomics is not going to diagnose you with IBS, but it will highlight some genetic variants that might make you more prone to inflammatory conditions. So, for example, there's interleukin 23 receptor. There may be a variant with that receptor, or ATG 16L1, which is autophagy-related gene. These two genes actually influence the immune system and inflammation as well. So I wouldn't be surprised if he had these variants, and they're at all if he were to do a nutrigenomic test. And they've actually been associated with conditions like ulcerative colitis.
It's incredible. And there's the finding there that you're dialing into that. So that's what I'm saying. Like there's so many situations where patients are going through something, and you have specialists, and you have the pediatrician, and you have the person that is dialing into the data, or EKG expert, or whatever it is. How many times are they missing out on a pharmacist? Like, wait a second.
Yes.
What about, what's this person going through? What's this little person going through? Or what's this senior going through? Or what's this person that's experiencing pain going through? And it's giving us an opportunity with Symptomatic to really dial into these cases. And like you said, Tamar, being able to say, hold on a second, there's an extra element to this. It ties back to the basics of every human being on the face of the earth, and that is consumption of substances and foods and whatever it is that literally impact our lives. And people aren't dialed into that. Some people are. I mean, you are, Tamar. I want to set up a separate appointment just for my own health.
Anytime, Todd. But it's we can't forsake that. It has to be integrative, right? Because you can't just focus on one thing when it comes to treatment or management of these disease states, or even diagnosis of these disease states, because these diseases are so complex. So definitely taking a holistic or integrative approach to look at a variety of factors.
Yep. Excellent. Steve Beckman, I tell you what, you and I come at things very similar, because we have more of a business background than a clinical background, but our backgrounds tie into making sure that our pharmacists, who are the most trusted healthcare professionals out there in their communities, are getting what they need. And so I thought, wow, I need a business guy here to be on my side of the fence, because there's too many questions out there tonight.
Well, again, it's a pleasure to be on the podcast here and with this fine panel. I think, look at, in the pharmaceutical industry and how we deliver drugs that help patient outcome, we've done things the same way for a long, long time. And to be honest with you, I've been doing it for over 35 years, and a lot of the things that we've done have been wrong. We do a lot of qualitative research and quantitative research, and a lot of that stays at the physician level. And what we've lost in that over many years is that we haven't translated down through the value chain of healthcare, especially with pharmacists and the patients. And that's what's great about this platform, because at the end of the day, a lot of times we think we know what our patient populations wants because we've been experts in delivering respiratory care or in asthma or COPD or whatever area you want. But what we forget is at the end of the day, the most important thing we can do is listen, we learn, we think, and then we act. And that's one of the things that we're trying to do as an organization is actually listen more to the end user and kind of work our way back up the kind of the pathway than down the pathway. And I think through that, we have the ability now to start really listening to what the real needs are. And that starts and ends with me, with the patient. That's why I joined this industry, is because I wanted to do something that would help people. And I'm not a trained scientist or I'm not a physician. I'm just a caring business guy that wants to do good. So I think what's great about the platform and listening to patient stories is that we can now translate in a different way than we've done before, or we can listen in a way that we've not done before and then translate it. And when we do that, I think it gives us the opportunity to rethink about how we can deliver better value. And when we think about drugs, we need to be thinking about patient cohorts under a therapy. You can't just say somebody has asthma, so everybody has asthma, and the drugs that we use are all the same. Pain is a big area in our business right now. And, in talking and working with Mark, one of the great things he's shared and has really impressed upon me is options in pain are very important. So how do you navigate those to get it down to the patient that you can create real outcome? But you can't really do that if we don't listen to the patient. And we've always, again, taken it from the top down. And we've looked at things like comorbidities, and things like that, and try to navigate all that. But really what we have to understand is we have to get even more sensitive to be able to deliver products that meet the individual needs. And we have a product for levothyroxine. We have a product that's unique from a dosage form, being a gel cap versus a tablets, which is the dominant form factor. But a lot of patients have tolerability and allergic response to many of the inactives in these generic levo tablets. Our product only has 4 ingredients and doesn't have the same profile. Now, as a company, we're not trying to go out and satisfy and convert all patients to our product, but there's 10% of those patients that would benefit from that. And that's what our requirement is. If we service the patients well, the business will take care of itself. And the best way we service patients, if a patient's not compliant on a drug and there's an alternative, but they don't know, then how are they going to find out? And where that starts, and where I believe that really starts, is with the pharmacist, because I believe in all the work I've done that pharmacists are either tracking because the patients aren't filling their chronic medication. They realize they're not refilling. So there's a reason for that. It could be price, it could be tolerability, it could be whatever it is, or the patient's coming to them first in many cases. And that's where, as an organization that we've actually taken a very different approach to do that bottom up. Not only listen to the patient and so forth, but we actually spend more money right now investing in the pharmacist than we do on any other healthcare provider. I'm not taking away all the importance of all the healthcare providers. Yeah. But the one healthcare provider that's been probably the most underappreciated in my entire 30 years has been the pharmacist, and that's something that we need to do more of.
Thank you. I appreciate you being here. I'm excited to have you in this show, Ryan, because you really come at things 4-dimensionally from so many of the conversations that we've had about health. And also a shout out for you really being a hero and an assistance to your community in what you went through with the latest hurricane that came up and just knocked out North Carolina. So I'm just glad you're here.
Thanks, Todd. I appreciate that. Yeah, Hurricane Helene was a beast, but we prevailed without a doubt. And we're thankful and grateful to be safe and sound and be able to have the resources to be of service to our community. So we'll keep after it. We didn't go back down to St. John, right? We stayed here. So with that said, I'll take it from kind of a two approach. Number one, I love Symptomatic because it reminds us that the patient is always at the center of everything that we do, right? So if we can center the patient, no matter what the conversation is, we're going to end up in the right place. But as an epidemiologist, and a lot of people don't know even what an epidemiologist is, but as a pharmaceutical epidemiologist, we really study the distribution, determinants, and deterrence of health and disease in populations, right? So for us, information is crucial for developing public health strategies, guiding healthcare policies, and prioritizing research investments. And I'm going to hold off on my excitement about the mental health aspect of IBD and talk about the gut-brain axis, Dr. Tamara, because I want us to talk about that. But what I wanted to really touch on is that, the future is promising as it relates to genetic research. And so if I take off the epidemiologist hat and I set that down and I put the investor hat on and I think about what type of innovation we want to continue to invest in from a biotech perspective, it really is that innovation that ultimately centers the patient. And again, the reason why I love Symptomatic, and really, quite frankly, the reason why I love pharmacists. I grew up in a pharmacist family. My grandfather was a pharmacist. He owned a very large chain of pharmacies called the Apothecary Shops. My mom was a pharmacy tech for him. I grew up walking in and out of the pharmacy. That felt like home to me, right? So when I started deciding what I was going to be, when I decided to be an entrepreneur, I knew it was going to be an entrepreneur in the pharmacy space. So I'm excited about what this panel is doing because they're innovating, they're bringing new ideas to the table, and we're actually able to help them execute on those ideas. So whether it's IBD, whether it's acromegalia, as we'll talk about in a little bit, there is hope for healthcare yet in the United States. And this panel is a representation of that.
Absolutely. Thank you for being here. And thank you all for being here. So I'm excited to kind of dig into this next case. And we're going to come back to Josie too, because I have some additional questions, but just going to keep the openings for each of these going. And that was Kelly. And, by this time I understood what I was going after. I was understanding based on Josie and the relationship with his mother and what he went through with IBS. I couldn't have thought of that as one of my children, not so much myself, but I started thinking about my daughters and stuff like that. But then Kelly came in and she's like, okay, I don't know what's going on. My weight gain and, misdiagnosis of subject to brain surgery. And she was, it was just like genetic revelations. And it was just like, I was like, this is the one, like, this is for my pharmacist family. So starting right out of the with Becky, take it away with regards to Kelly and what you were thinking.
Yeah, when I agreed to join you guys, I didn't realize that one of the episodes was on pharmacogenomics. So as I'm listening and I'm hearing Kelly's story, I get goosebumps because the number of people that may be experiencing adverse drug events, but that's not what they're recognized as. In her case, she was diagnosed with acromegaly. They wanted to do brain surgery on her. Those are very life-altering, needless to say. And I just wonder, because I didn't hear in her story, was there a pharmacist that was involved that understands the genetic basis of adverse events, drug events, and non-therapeutic drug outcomes that might have recognized? It took her seeing her doctor at Mayo Clinic. And, Mayo Clinic is very well known for pharmacogenomics. They're some of the pioneers and some of the godfathers of pharmacogenomics came out of Mayo, needless to say. But, how many patients every day walk into their doctor's office describing symptoms of what they think may be a new onset condition or advance of the condition they already had, when it's actually side effects of a medication. Her side effects were extreme, and it took her a very long time to get to that answer, to find out that because she wasn't metabolizing medication appropriately, the medication was building up in her system and causing these toxicities. And the class of drugs that, I don't remember if she named them specifically. I believe she said they were for gastric reflux or heartburn, that may be how she described it. But proton pump inhibitors are one of the most commonly prescribed drugs on the market. And unfortunately, not only do they get prescribed, but then they don't get deprescribed after, the intended use period. And so you will see, I used to work in long-term care. We would see patients on these medications for years and years. And, we also know that prescribing cascades occur. So, along the lines, was the patient describing aches, pains, kind of like Kelly, and doctors were just prescribing more medications to treat those adverse effects. So that Kelly's case, absolutely, yeah, I was surprised. I wasn't expecting it, but it's the story that I tell. That's what I tell. That's my story. I talk about pharmacogenomics. I have that platform to help patients get to that information faster.
Yep. Oh, wow. I tell you what, that opened up my mind to pharmacogenomics. And when I started learning about that in 2016 and how that component of pharmacist leadership is just enormous. Mark, what about Kelly? What interested you about this, and what were you thinking of before you actually realized what the conclusion was?
So, what a case! What a human! Let's humanize these cases. This podcast, certainly Symptomatic, does that effectively. It's very hard to do that. They do it very well, though. When thinking through, this isn't like one of those things like, oh, is there a fault? Is there a whatever? Mm-hmm. Within this panel, I think when being invited, there's natural presumption, hey, maybe one of our specialties will come up in cases. Me, I'm like, of course pain will come up. How does it not come up? It's literally everywhere. That stinks, but it's literally everywhere. So, and I did, Todd, you know me best. I try to inject a little humor. I don't try and cross the line, but when you have these cases, it's very tricky to be like, hey, let's stop and learn here, for the future, for when the next patient presents with something similar. They'll probably never be the same, but it could be similar. And, with that in mind, it's that general idea of, do we want, in a world of Excel and spreadsheets and flow charts and how, the insurance side of healthcare has put everything into the clouds, like this one, yes or no, this one or this one, depending on where you go, and all these flow charts. And that has become the art of diagnosis and sometimes treatment as well, too. Mm-hmm. When who I want in the background, who I want for Kelly, besides fine folks on this panel, I want Alan from The Hangover. I'm going to give that a second or three. Okay. Most people have seen remember in the movie or seen the meme or picture, whatever we want to call it. And it's when he's thinking and all the math is going through, he's trying to, do his thing with blackjack. But all the numbers, all the things are floating through his mind. You know what's not floating through his mind depicted in that scene? Flow charts. It's not ask this, get yes or no, go to the next thing. It's there's a human presenting something, talking it through, or even a chart, and you're looking through, you want all the options. Would it have been great if Kelly saw Dr. Becky like at the beginning of the case? Heck, if it's my mom or me, that's what I want. I want that pharmacist. She's sitting right there. The rest of y'all too. And then it becomes boring, but in a good way, in a compassionate way, because it's done. Case over. Pharmacist rocked it. And that's what we need. We need more of that. Like that's I'm sure anyone could piggyback on that one, but
absolutely. And it's true. It's a it's a missing link because it's not a natural part of our flow. And you get to the medical record and the physician's like, okay, what's my next step? Why aren't you kicking this off to a pharmacist? It has nothing to do with dispensing. It has to do with dialing into the individual.
Exactly.
And that's your whole gig. So talk to us about Kelly.
Yes, Kelly. Okay, so 3 things I want to talk about with Kelly. First, patient advocacy and empowerment. Once she advocated for herself to find another solution, wrote the Mayo Clinic herself. And then that empowerment she felt when she actually understood that it was related to the medications and her genetics. Like you could just hear it in her voice, like how, although it's already happened, it was like it was happening again, like she was discovering it again. It's so important, again, patient advocacy. It's important for them to feel empowered that they can take action when it comes to their health. The second thing, remember, she started out talking about migraines since she was 16 years old. That's where this all started. Migraines when she was 16 years old. It's a family thing, I believe is a quote unquote, is what she said. So migraines ran in her family. I'm looking at my notes here. So it wasn't until she was 32 years old after her 3rd pregnancy where she started having heartburn, and then she was put on PPIs. So for my nutrigenomic mind, with my goal to reduce the need for medications in my clients, I'm thinking at 16 years old, there are triggers for those migraines, right? And later on in life, heartburn is also a trigger for migraines as well. So it probably preceded her migraine, her migraines coming on when she was older. But knowing what your triggers are, but then genetically, there are several factors we can look at as well to determine your risk of migraines or what might be contributing to your migraines. And from a nutrigenomic perspective, we can then fine tune your nutrition plan, your lifestyle plan. Inflammation is very much involved with migraines, detoxification, oxidative stress. We have that gut health, that gut-brain axis relationship, again, is so important when it comes to migraines. A lot of people don't think about that. What's going on in the gut affects our mind, our brain. So from nutrigenomic perspective, we can then narrow down the type of foods that she can avoid and also that she should be on to help mitigate the effects of those migraines and potentially never have to be put on PPIs as a result of GERD.
Yeah, I want to bring you in, Ryan, because you did mention this to me in text before the show started. And so I want you to kind of jump on what Tamara was talking about and how you were saying.
Well, Dr. Tamara is right on. And I imagine she's right on 10 out of 10 times. But, I was actually referring to Jose, right? Because there was a specific conversation about mental health, right? And we know that there is a lot of issues as it relates to mental health when you're talking about IBD. But, the gut brain, if we're going to jump into the gut brain axis, and just so the audience kind of has an understanding, it's a bidirectional link between the central nervous system and the enteric nervous system of the body, right? So it is basically what we're putting into our gut. It's creating a microbiome in our gut, and that is impacting the rest of our body, and it is impacting our mental health, right? Like, so for instance, gluten. Gluten is an offender of mental health. Dairy is an offender of mental health. And so that's what I was talking about, Todd, when I sent you that text was, so from an and so like kind of to transition back to like the way that I see it from an epidemiological perspective, I'm automatically going to go back to, and to Dr. Mark's point, we don't want, right, the check the boxes, if this, then this, if this, then this. But on the same token, to train really great diagnosticians, they have to start there, right? So I'm going to ask, what's the prevalence and incidence? What's the age of diagnosis? What's the diagnostic delays? What's the impact on quality of life? There's lots of things from an epidemiological perspective that we are going to put in quote unquote boxes and kind of hand off so that the creativity can happen, right? So if there is some paint and a paintbrush so we can hand it off to the PharmDs of the world, the physicians, so that they can be the artists and they can start to paint and get creative about these diagnostic opportunities. I mean, here's the reality. With acromegalia, it's 60 out of 1 million, 60
Right.
cases out of 1 million. So the chances of knowing that in the onset is virtually impossible, right? So the question then becomes, what do we have to do, knowing that it seems virtually impossible to make that diagnosis in the beginning? That's where research scientists like myself have to do a better job with the information that we're given, so that we can create some boundaries as it relates to what's happening with the population, based on region, based on demographics, based on geography, a slew of things.
Awesome. That's awesome. Thank you for that. So, Stephen, you and I share, viewpoints in some ways, but you're a little deeper than I am from even a clinical perspective because of your background of just being in it for so long in pharma. But I was thinking of this as, hey, if my daughter was going through this perspective, and how sickening it would be for me as a parent. What did you think about Kelly's case?
Well, Kelly's case actually, to take it home personally, really translated to my own daughter. I have a daughter who's 26 years old, and she was diagnosed at 6 with migraines. And we have struggled for 20 years. And at first it was manageable for certain things. And then as she got into high school, all the comments, especially made by Ryan in terms of the mental health part of this, is an amazing interplay between the physical and mental. And when you see that we searched out answers everywhere, but we had a very difficult time. And I think it was because we didn't really have the balance of that structured quantitative side and the qualitative side that Mark was happening at 26-year-old. My daughter's still not fully functional in today's world. If we had these tools, we would be better off. So I know when I listen to some of these cases, this one really hit home for me because, for me, what it means is that we still need to do a better job of doing the quantitative and the functional side that Ryan was talking about. We have to check the boxes right. But to Mark's point, we've got to find a better way to bring the patient into humanity, because I've lived it with her forever, and I still don't think I truly appreciate what has struggled. She has struggled on the pure management of having severe migraines 2 or 3 times a month. And as a result, when she got to college, she actually tried to commit suicide because it had consumed her on a mental health perspective. Now spent equal amount of time trying to solve both sides of this equation. And that only comes, the only answer we're going to get is that we've tried to put all these pieces together more effectively. And my goal, and has been for the last 20 years, is to try to help her find that outcome and answer. So, nutritional aspects, we haven't really actually gotten into as much, which is very interesting. So, Doctor, you and I might be having some more conversations on the podcast. But we've tried everything else. But we also took it from more of a traditional approach, and then we went to the non-traditional approaches. So, I think we almost did it backwards. We kind of followed a traditional path, and we didn't step back and actually better evaluate when the time has happened, when did it present, how it was presenting, how it was changing, and approach it different ways. And when I think about it now, and been preparing for this and having comment, the one aspect that we also missed out a lot on was the pharmacist input on this process. And that's been a big regret. So we've worked with a lot more pharmacists than last year. And she's actually, I'm happy to say, has made some progress in the last 24 months to the fact that she's now gone back to get her master's degree, or almost complete her master's degree. And my hope is that what has translated into a very difficult start to her life and a feeling of not being healthy and productive, is we're getting closer to turning that page to being a productive part of society. And that will be probably the greatest accomplishment I will ever witness personally to see them achieve that goal.
That's special. That's special. Thank you for sharing that with us, Stephen. I appreciate that.
Yeah.
And thank you to this panel so far. This has been dissecting these cases in different perspectives. And every single one of you have brought something to this that I never thought of before, and really going deeper with Symptomatic, and how many healthcare providers who aren't listening to this show, if this is the first time you've ever heard of Symptomatic, go to any of your podcast players and just put in Symptomatic. It'll come right up, guarantee it. And it's been an addition to my podcast player, obviously, because of just catching up and understanding. And I always listen to a couple of these before we went to the NASP, which is the National Association of Specialty Pharmacy, which is digging down into rare diseases. And so when I thought of this next case, which was our case in Scott was our patient, this one was the most intense of the three for me because of the fact that Scott almost died. And it was that's as scary as it gets. So I want to bring in Becky and just jump right into this one.
Well, I think it's important to bring up the fact that now with medication, as medications evolve and treatments evolve, they're going to be more precise. Okay, so medications that are being introduced into the market now, for the most part, are not general medications, or they're not non-specific. They're very precise medications. And I just want to make sure that we're letting patients know, physicians know, that if a companion diagnostic exists for medications that are new to the market, that's the perfect scenario, because companion diagnostics are required to determine if a medication will be effective for a patient or if it's less likely to cause side effects. We see these companion diagnostics frequently in oncology. We're starting to see them more in non-oncology settings. But I think it's very important that we point out this opportunity that the patient needs to know about, so that the patient doesn't have to tell the story of I almost died before I got, the help I needed. And so we're going to be seeing more and more precision medications designed specifically to treat conditions. And I'm sure that Ryan can speak on this, as a scientist, and how medications, as we research the variants amongst patients that experience these conditions, and we can identify the common variants amongst these patients so that we can figure out how to treat them precisely. That is where medicine is headed, and being more precise.
I love it. I love it. Well, you're tagged. It was Becky. It's like a big ring. So
yeah. So I'll keep it short because this one can turn into a dissertation, because I have this conversation a lot. So number one, Dr. Becky is 1,000% right. That is where medication's going. But here's the issue with that: it treats less people, right? The marketplace is smaller.
Yes.
And so, I'll put on the investor hat for a second. I had a conversation today with a biomedical company in what we call an alpha group. And we were having the conversation about how we actually raise capital for these types of innovations, knowing full well that the arc of capital return is far away. And so really what we need in precision medication, and I think it goes back to, is the patient at the center of the motive, right? Or is profit just the motive? Because quite frankly, I can just tell you that for many years, profit was my motive. It wasn't until some radical, wild things happened in my life, some really hard, difficult things happened in my life, to where all of a sudden I just viewed what my calling was very differently. But we're having difficulty raising capital around precision medication. And so guess what happens is that precision medication is then shelved and the smaller companies, right? The VCs, the private equity firms, the companies that are operating with less than 100 million in capital. And you think that that's a lot of money. It's just simply not in that space.
All right.
But if we're operating with about 108 to 115 million at any given time, we don't have enough money at a 2% administrative fee to be able to even walk through the door from a research perspective. So you have the Eli Lillys, you have the Pfizers, you have the Johnson & Johnsons that are shelving this medication, which means that healthcare in the United States needs to change first, right? It means that we need to start taking a look at who's funding this innovation and how we're going to bring some of the smaller players in to make it happen. Because we can talk about the science of it all day long, but the reality is the patient doesn't really care about the science. They don't care about how the soup is made. They just simply need it.
Yeah.
I appreciate that.
Affordability is a big issue. And, not only in the medications, but the diagnostic testing. So, payers, I work in market access and reimbursement for the most part. And, proving to payers that they'll see a return on investment in a product.
Yeah, if I could add, Todd, I think Ryan made a very good point. I love what he says about patient-centric, because that's ultimately what we're all here in some way or some form. It's about the patient. The problem is that our system doesn't allow us to truly be patient-centric. When we look at our industry, and a new NCE can fully capitalized could be anywhere from $500 million to $1 billion. It's different obviously on the generic side, but the generic side's getting even more complicated, more like brand, because we're now moving into more complex drugs, programs that cost more with greater risk. So we're even the generic side is acting more like brands. I'm going to say something controversial, especially for somebody who's in the industry, is we have to change fundamentally a number of things. We need to change our patent laws. Our patent laws do not allow for innovation. It does not allow for companies to invest even on more precise medication because it's not profitable. We need to get rid of direct-to-consumer advertising. If we spent the money and took away direct-to-consumer advertising and put it back into what we should be doing, we could do a lot more better. And in many countries like Europe or in Europe, European Union, you can't do what we do here. So I know that the people that that pull ads on the Super Bowl would be unhappy with me, but the fact is that we're not doing things that are patient-centric. We have to find ways to relook at what we're doing to re-incentivize companies to take those projects, because they are important, and put them back into mainstream. But that also means we have to change things on the delivery of healthcare, because manufacturers manufacturers over the year have always been the scapegoat, and rightfully so in many cases, but not all cases. And the industry on the manufacturing side is not as evil as we're out to be. There's a lot of other players that are taking a lot of the profit out. That makes it difficult for manufacturers to continue to invest in development. And as you see it, when I joined this industry back in 30 years, the Mercks of the world were the most admired companies in the United States. And they did, because they were reinvesting 28% of their profit back into R&D. Now, most of these large organizations do not have the R&D budgets because they've had to reduce it to create profit, to keep people happy, and they've gone out to see CDMOs, and that's where all the expertise has gone. And we've got it all backwards again. So we need to reframe it again, and I think through that we can actually deliver these type of products that will add value, that will deliver down to more subpopulations within an individual indication, and that's what we need to ultimately drive to create better value and outcome. But if we don't change the system is working against us, and we need to give manufacturers an opportunity to do it right, and we can. But to do it right, we have to take some of the risk out of it for us. We can't invest $500 million and take 12 years to get a product and only have 5 years to make your capital investment back. Right. So we have to find a way to create that new balance. But I like what Ryan had to say, because if we can reset to being patient-centric more. We talk about, and we do a lot of things. We do patient advocacy efforts, and we do roundtables, but we're not really doing what I think Ryan's articulating. And at the end of the day, when United Healthcare is one of the largest, most profitable companies in the United States of America, that tells you right there and foremost that the value of where the healthcare dollar is going is not going to the right place. And that's what we need to change. But fundamentally, this is a bigger picture than any one of us can do. But if we all work together in a more integrated and syndicated way, then all can play a part to giving better healthcare outcome.
Thank you. Thank
Thanks,
you,
Steve.
Tamara. I wanted to jump right in and you jump in and kind of think about what Scott was going through and what was coming up in your mind. I can't hear you. Are you muted?
I sure was, Todd. Can you hear me now?
I can hear you now. Good.
Scott's case was very complex. I agree with what everyone is saying here, where, we need to, healthcare should be patient-centric. It should be about the patient, not about a profit. How do you go about changing that? How do you do this huge overhaul? Because it's so ingrained in our system here and in the Western world. I really don't have anything else to add. I agree with what everyone is saying and some very valid points when it comes to this case.
I was concerned with multi things falling apart. The effect on his heart, the effect on his lungs, like things started collapsing. And the only time that I've ever experienced that personally in my life was one of my great aunts passing away. And she went in because she was having kidney issues. And then all of a sudden, everything else started to
Shut down.
fall apart and shut down. That's scary. Like that's like, how do you catch up? How do you, what the heck could you do to help sustain or catch up or prevent? And so that's definitely something that came up in my mind, I think, as the consumer of it all. The least experienced to the clinical level, other than just listening to you all for the last 20 years. But I think that Symptomatic has a really interesting opportunity here, and that is to look at season 4, look at season 5, and moving forward to really start putting a new spin into this, which is how do we get pharmacist insights involved, and how do we let the public know that you're missing a part of your 360 degrees of healthcare, include mental health, like Ryan said, that include the trust of your medication working as intended, as Becky can dial into with pharmacogenomics. What's the impact of when everybody was talking about migraines? My two sisters, Tara and Teresa. Teresa is actually a nutritionist, a registered dietitian. She was, even at a young age, 12 years old, was obsessed with understanding, why do I get headaches all the time? And sure enough, both of my sisters are very sensitive to gluten and live gluten-free lives. Now they don't deal with the headaches as often. Every once in a while something comes in. But I immediately started thinking of, wow, there are aspects of what people live with day in and day out that we're missing it because of the pressures that we're putting on our physicians to always be right. They're human beings. And they need more support, and they need to take the treatment and kick it off to their pharmacist to dial in and really give them another opportunity to having to see 30 or 40 patients a day. No wonder these poor people, Scott and Jose and the rest of them, are overlooked because of how the healthcare system is just a churn and burn and churn and churn and churn. And let's just get it, go, go, go. No, it's time to slow down. One thing Symptomatic has taught me is to slow down and to take time to listen. I'm not a clinician, but if I would have sat with, Mila, Case 22, Scott, Kelly, Jose, if I would have sat with any of them, I would have taken time to listen. One thing I've learned in 16 years of podcasting is definitely listening to some incredibly intelligent people like yourselves. I'm going to kick it off to Ryan real quick to speed up some of the things that we're talking about, because I do want to get into this latest case, which was Mila.
So I think that I'm going to have to pass on this one, Todd, because I don't think I'm familiar with Mila case. I thought we had 3 cases.
Oh yeah, we did have one. As we're talking live, this one just posted like 39 minutes ago. As we
All right, you're throwing us a curveball here, Todd.
were on
We're
top,
good, but not
Let's
that
give it
good.
Ryan.
Ryan,
No, I mean, it's
Ryan, thank
okay.
you for taking the bullet for us. I appreciate it.
It's okay.
look, we threw him a curveball, and he just to jump into it. No, that's hilarious. No, I'm blown away tonight by how well each of you leveraged the expertise that you have in the verticals that you have, which tells me that more collaboration for patients, the better. Of giving our nutritionists and our pharmacists and our nurses and our physicians and being able to take some of the pressures off of each other. I can't wait to work on some pediatric cases. Shout out to Dr. Jenna Quinn, who's on the Pharmacy Podcast Network as our pediatric expert, dialing into geriatrics, dialing into dementia. A shout out to the Symptomatic team. We want you to leverage our pharmacy network, and it's more than just pharmacists, as you can see tonight with Stephen Beckman and Ryan digging into epidemiology, Ryan Paul, and the quality that you've all brought tonight. And in closing, I just want to say thank you, Becky, for being the first one to respond to the request to participate in Symptomatic tonight. And from
I
there,
love a mystery.
Beat me.
just call it
I
out.
love a mystery.
But
I have a bad habit of watching mysteries.
We're just getting warmed up, Todd.
This,
That's hour number 2.
listen, this is not Joe
What are we
Rogan.
talking about?
Joe Rogan, where we podcast for 4 hours. We're trying to stay in the
In the hour window. But hey, look at Todd. You said something that was really important, and we all have to listen more. I'm actually starting to write a book, and I wrote the foreword today. And the first thing, because I came into my head, was the most successful thing I've learned in my business to be successful in business is to listen first. Less is more sometimes, but we need to give the pharmacists. I was on with Walgreens team just yesterday in our discussions, and the first thing they said is we don't actually have time to talk to patients. Independent pharmacists, obviously, that's been their core essence, and they stick to it, and they still deliver it more. But at the same time, it's hard for them to keep a business profitable. So we have to find a way to actually deliver what everybody said on the phone and pull it all together in a more comprehensive way. And thanks. I learned a lot tonight, guys. So appreciate hearing from all of you.
heck yeah.
Let's
Mark,
do it again.
fun having you in this and just understanding from your perspective, but you listen and you dialogue with the future of pharmacy too. I'm not sure if you told anybody that.
Getting to teach our student pharmacists and other healthcare professions too, whether it's a pain fellowship or other health sciences schools, it's thrilling, to see the minds that are, innately we start out more listening. Usually, folks will stay awake for class. Usually, if I'm teaching about illegal drugs or something, that's a no-brainer. But impacting the future, it's like you get thousands, tens of thousands, if not hundreds of thousands of patients help by impacting the future of healthcare really too. Something that something resonated with me. It was like 40-ish minutes ago. I believe Dr. Becky said something, and what I translated it to, because you definitely didn't say this, my apologies, was like chicken or the egg. And when it comes to medications for treatments, which one's at fault? Like in some of these cases that we were on the edge of our seats for in Symptomatic, it's like, we obviously had the one, I think it was Kelly, with, the medicine's actually at fault. Like chicken or the egg, which one we got here? I've had cases, in pain management, it's like the gateway of gateways. Because the problem isn't always pain. Boy, it sucks. But the problem is probably something else causing it, right? And we see this almost all the time in pain management, where, you have a patient with diabetes, and then all of a sudden, hey, I think I have peripheral diabetic neuropathy because I saw the ad that Stephen talked about that was made legal 50 years ago in our country. And I think I need that drug. And you're like, whoa, let's just skip past the next 3 months of trying to figure out what you got going on. Like it's chicken or the egg, in that case, maybe it's, one of the medications to treat your diabetes might affect your vitamin B12 absorption.
Ah.
And then two other panelists here are going out of their minds of like, that's so simple. We learned it the first year of pharmacy school. And that's where we help. That's where pharmacists come to the table. It's oftentimes what's most common sense to all of us, because that's what our training is. You know, I'm a pharmacist here. Us roar. That's what Symptomatic needs.
Yes, absolutely.
Our mics are all attached. So I would.
Yeah. Well, this has been awesome. This has been our first go at this. This will not be our last. Symptomatic, a medical mystery podcast by the iHeart Media team, the Ruby division. A shout out to your team. A shout out to Ethan and Jody and Amber, who I've been working with in the inside of the Ruby iHeart team. And thank you to my panelists. Thank you to each of you for taking the reins to be my guinea pigs and be available to us tonight to throw you out there into the podcast wolves to give us your assessment of each of these cases. I really appreciate it.
Thanks, Todd.
Thank you.
Our pleasure.
This was fun. Had a blast.
Thank you all.
Right. Well, listen to all Symptomatic by going to iHeartRadio. That's iHeart.com and register and look up Symptomatic really on any of your podcast apps. Subscribe to Pharmacy Podcast Network to tie into the leading pharmacists in healthcare. And that's right here on the Pharmacy Podcast Network. We'll talk to you next time. See you.
See you.